recognise Reconciliation Week. As always, I encourage, it's great to see some people here in person. These seminars are always better in person. And I see there's some people online. I encourage those who are in the precinct to get out of their offices and come down here and join with us for this really important and special seminar. And if we can entice you down with a little bit of nice lunch afterwards, then we have that as well. So I'd like to start off, obviously, and keeping with the theme of the seminar, by acknowledging the Burrong and Wurundjeri people of the Eastern Kulin Nation, who are the custodians of the lands and waters which we live, work, and thrive, and we pay their respects to their elders, past, present, and emerging. So this CCS special seminar is being organised by our Equity and Diversity Committee, so I'll pass over to Hugh Simpson, who's on that committee, to introduce our speaker.
Thanks, Terry. Good afternoon, everyone, and welcome to this special STM seminar. So I'd like to welcome Dr. Anna Balabanski, a friend and colleague of mine here at Alfred Health. She's a neurologist and stroke specialist working across Alfred Health, Royal Melbourne Hospital, and Alice Springs Hospital. She has an interest in stroke and particularly in improving service delivery and outcomes for stroke in First Nations people. She completed her PhD in the epidemiology of stroke in Aboriginal and Torres Strait Islander Australians, and is now a postdoctoral research fellow through the University of Melbourne. She continues to accrue titles and accolades faster than I can remember, but amongst other things, she's also now the Deputy Director of Neurology here at Alfred Health, in the Neurology Department at Alfred Health, and she's the Acting Head of Stroke here at Alfred Health as well. So I'd like to welcome and thank Dr. Anna Balabanski.
Thank you very much, Terry and Hugh, and thanks everyone for being here today. I think it's wonderful to have the opportunity to reflect on important things such as First Nations health, and so fantastic to have this opportunity in Reconciliation Week. I'd also like to acknowledge the Boonwurrung and Wurrung people of the Eastern Kulin Nation, who are the traditional custodians of the land on which we're meeting, and pay my respect to their elders past and present also. I'd also like to acknowledge that the statistics presented in this body of work represent the loss of health and human life, affecting individuals, families, communities, and culture. And these numbers also obscure the resilience and strengths of the people involved. I have no relevant disclosures other than the fact that I myself am not Aboriginal. I am of European descent. And whenever I talk about the research that I've been involved with, I think it's really important to understand where and if any of you undertake First Nations research, where you stand, what your position is in relation to the research in question. I've had a long-standing connection to Aboriginal culture. When I was a child, I had a lot of Aboriginal friends. I spent quite a bit of time in remote Aboriginal communities with my parents. And my parents set up a program where Aboriginal kids from remote communities would come down and do their schooling in Adelaide. And as part of that, Shakayla, who's pictured here, and I'll explain this picture in a little bit more detail, ended up living with my family. Shakayla is an Aboriginal woman from Punya, which is the Larutja group, which you can't probably see, but is in the green and orange on the language map. And Shakayla's father became very unwell of cardiovascular disease and died when he was just 45. Before he died, he, on his deathbed, named my father her new father within the community. And because of that, my family were then recognised as part of the Punya community. My skin name is Nampi Jimpa, which means that my whole family have skin names. My husband has a skin name. And it's a real privilege to be invited into that community. Beyond my personal connections to Aboriginal culture, I have had a long-standing professional connection partly through my work through my PhD, which I actually started doing that research when I was a junior doctor a long time ago, working up in Alice Springs. I also have a close working relationship with my dear friend and colleague, Dr. Angela Dos Santos, who worked here for some years before she moved to New South Wales. She's a Queanbeyan Gumbaynggirr woman from the mid-north coast of New South Wales, and she does incredible work in this space as well, so I want to acknowledge her. And just to mention in this picture, so I do continue to work in Alice Springs. Shakayla's living there at the moment, so she took me and some of my friends out to do barbecued routail by the Upapa clay pans. It wasn't quite as authentic as she would have liked, because we didn't hunt the root ourselves. We had to get the routail from the local supermarket. But if any of you are ever in the Territory and have this experience, I'd really encourage you to do so, though if you're vegetarian, it might not be ideal. So I think before I get into stroke in Aboriginal Australians, I wanted to provide a bit of context for those who may not have had a lot of experience doing work in this space. And whenever we consider working with First Nations people, whether that be in Australia, Maori and Aotearoa, New Zealand, or around the world, it's really important to recognise that health research historically has not always been done with the intention of benefiting Indigenous peoples, sometimes directly, sometimes indirectly, but historically this has resulted in significant harm. And this is why there are always additional layers. If you want to do a research project in First Nations Australians, there are additional steps that you need to go through. Additionally, health inequity, including that I'm going to be talking about today, really can't be understood without considering the social determinants of health, which underpin everything that we see, many of us here are clinician scientists and researchers in a healthcare setting. And also, it's important to recognise that these inequalities have frequently been described as being due to poorer behaviour of First Nations peoples. Often when I'm talking about the research I've been involved with, people will say, oh, isn't it just because, because Aboriginal people smoke too much or drink too much? But when you actually drill down to it, that's often not true. And that certainly isn't the reason that we're seeing these disparities. And this brings me to the deficits discourse. It's a difficult concept because when we're talking about Aboriginal health, we should be avoiding describing Aboriginal health in terms such as absence or lack or failure. And this means we shouldn't be using words like vulnerability. We shouldn't be describing health with these negative connotations. And this is because it promotes inaccurate and potentially harmful misperceptions of the existing health disparities. This is because it can directly or indirectly perpetuate individual and systemic racism, and it can promote continued imbalance in power between Aboriginal and non-Aboriginal people. It's a barrier to effective implementation. If you're always talking about people as being lesser, they're not going to engage in the initiatives that are put to them, and can reduce uptake of culturally safe healthcare. And as you can understand, putting yourself in the shoes of people who've been studied in a potentially exploitative way, this creates an ongoing reluctance for involvement in research. So it's important to reframe the approach to what we're doing when we're working with Aboriginal people doing research and healthcare interventions. Such interventions need to be shaped around Aboriginal people's own notion of health, and I'll talk a bit more about that later. The research and interventions need to be conducted in a culturally responsive manner, with Indigenous governance and oversight, and very importantly, with community consultation, engagement and partnership. So now on to stroke and cardiovascular disease globally. So just 3.2% of the Australian population identify as Aboriginal. Now, a caveat here, because most of my research focuses specifically on Aboriginal people rather than Torres Strait Islander, and because the populations that I study prefer the term Aboriginal, that's the term I'll be using during today's talk. Their well-being, as I've mentioned, has been impacted significantly by the social determinants of health, And as a result, the vascular health outcomes are not what we see in non-Aboriginal Australians. Cardiovascular disease, including stroke, is the second leading cause of death, comprising nearly a quarter of all deaths in the Aboriginal population. 15% of these deaths in cardiovascular disease are due to cerebrovascular disease, including stroke. There are increased rates of disability and hospitalisation. And I'll just give you a moment to have a look at these and really consider, again, partly for the benefit of clinicians, but also of the clinician scientists in the room. We often think about disease risk factors and biological risk factors, and that's what we're really targeting, that's what we're measuring when we do this research or when we try to implement care. And we might think a little bit about lifestyle factors, substance use, diet, etc. But really what underpins this are socioeconomic and environmental factors, poverty and job insecurity, unhealthy environments, educational disadvantage, and there are political factors, loss of traditional home, loss of language, colonisation. And it's really important to really understand what underpins what we're seeing on the surface. For example, in many of the remote communities where I have my patients from when I'm doing work in Alice Springs, they'll tell me, oh, I haven't taken my diabetes medications. And I could just say, oh, that's just because of non-adherence, or maybe they don't understand. But when you take a moment to actually understand why they didn't, the reason they didn't is because the medication's gone off. And that's because they lost power, and so they weren't able to refrigerate their medication. And that's because to have power in a lot of these remote communities, you need to have a card which you take to the local shop to get recharged so that you can get power. And the local shops only open for a few hours a day on business days. And because they don't necessarily have access to fancy apps, because there's often no phone or internet reception, they have no way to know when their power's going off. And so when you think about all those factors, how can you blame them for not taking their medications? That's even if the medications get to the remote communities. When my Aboriginal sister Shakayla had medical issues and needed medications for her lupus, all of the roads closed down because of the flooding. And so she needed it to be airlifted to hospital because there was no other way for her to have a life-saving treatment. So I think it's really important to reflect on the determinants of health that underpin everything that we're seeing as clinicians, and really reframe our approach when we're considering the barriers to care. Now to the burden of stroke in Aboriginal Australians. Prior to the work that I was involved with my PhD, there was actually fairly limited data on stroke in this population, despite the fact that we know it has such a significant impact on their well-being. We knew that there appeared to be greater age standardised prevalence of stroke in Aboriginal than non-Aboriginal people, males having almost 4 times greater prevalence and females having almost 4.5 times greater prevalence. But as mentioned, the data were very limited. There were very few Aboriginal people in the gold standard prospective incidence studies that had been done across Australia. And the only studies that had looked at stroke incidence, and by incidence I'm referring to a first ever in a lifetime stroke, which is one of the better ways of measuring the burden of disease when it comes to stroke. There'd only been single jurisdiction studies using administrative data, and while there is a lot of benefit in administrative data, which I'll go into later, it does lack granularity. You can't nail down the underlying cause of why you're seeing differences necessarily. And this led to the development of the South Australia and Northern Territory stroke study that I was involved in leading. This was developed before my involvement in response to community identified needs back in 2014, where Professor Alex Brown, who's a Aboriginal man and leading cardiovascular researcher, presented at the National Stroke Conference saying, we don't know anything about stroke other than the fact it's killing a lot of my people, and we need to find out more about it. It's designed outlining barriers to care and designed to identify targets to influence health systems. And the goal here was not just to measure inequalities, but rather to provide best practice healthcare and improved health outcomes for Aboriginal people. And this is a key concept when doing research with First Nations peoples. It's not about measuring inequities, it's about finding out what to do and then actually doing it. So there were 4 components of the SAINTS study. There was a linked data analysis looking at whole of population data from SA, NT and WA, a retrospective study of Central Australia, a prospective pilot study and a qualitative analysis, so I won't be going into that in detail today. For the Central Australia study, this is something I remember recruiting for back when I was a basic physician trainee in Alice Springs Hospital, doing data collection and medical records on my quieter night shifts. And because Alice Springs Hospital is the only hospital in, basically between, I think it's Whyalla, or maybe even Adelaide and Katherine, that has a CT scanner, all of the patients in the catchment, it's actually a broader catchment than what we see here, but all the patients with suspected stroke need to come to Alice Springs. And the benefit of that is that allows us to have a quasi-population-based hospital study. This study included 74 Aboriginal patients with first ever in a lifetime or incident stroke. Then there was the data linkage study, where we took data back as far as 2001 and then took a sample from 2012 to 2015 with a prolonged look back to make sure we really were capturing those incident events. And this is the largest multi-jurisdictional sample size of Aboriginal Australians, so 675 Aboriginal patients in this study. And then there's also a prospective pilot study, which was led by Dr. Angela Dos Santos, who I was talking about before, which is a prospective pilot study looking at the population in Darwin, Alice Springs and Adelaide to examine the feasibility of doing one of the gold standard studies where you have multiple sources of ascertainment. You're getting cases from hospital, from GPs, from nursing homes, etc. And this will be published very soon in the Indigenous issue of the Medical Journal of Australia. And so I'm going to present the results collectively just to summarise. But firstly, incident first ever stroke occurs at substantially younger ages in Aboriginal Australians in different studies between 7 and 28 years younger than non-Aboriginal Australians. The differences are even greater for fatal incidents, so first ever stroke resulting in death. The outcomes in these patients with stroke are poorer for those living in remote and very remote regions. Looking at the data from the data linkage study across the 3 jurisdictions, the median age for fatal stroke, fatal incident stroke in Aboriginal women in remote and very remote areas was just 57 years old. And that compares to Aboriginal women in metropolitan and inner regional areas, which was 79. So that's a really notable disparity when considering the impact of stroke, particularly on Aboriginal women, and thinking about how we can improve service provision for this population. The incidence of stroke is significantly greater overall in Aboriginal Australians. What I'd like to draw your attention to is these 3 graphs, and the relevance of this is that the first study on the left was actually not officially part of the SAINTS study, but I took the 2 gold standard prospective studies from South Australia, combined the data and looked at the Aboriginal population specifically. Only 17 patients were able to be ascertained in this study, which was over 2 years in metropolitan and 1 year in regional Adelaide, regional South Australia. And the South Australian population have a higher proportion of Aboriginal people than Victoria, for example. And what you can see is that there's a lot of instability in the incidence graphs, as compared to the graph on the right-hand side, which is the which is the data linkage study. And you can see that the graphs are much more stable. You can still appreciate that the black lines there are, that is the age-specific incidence rate for Aboriginal people, which is significantly greater than the grey lines for non-Aboriginal patients. But our actual estimates are much more precise when using larger sample size, of course. And so rather than doing what we would typically consider a gold standard methodology, which is ideal for majority populations, these methods don't necessarily work very well in Indigenous or necessarily other minority populations. We can see the incidence rates were greater across all age groups, but the disparities were particularly marked at younger ages. Looking now to the Central Australia study, we found greater age standardised and age specific incidence. The incident rate ratios listed along the top show that in those Aboriginal patients admitted to stroke in the study period, those aged 45 to 54 years, if you're Aboriginal, you're 17 times more likely to experience an incident stroke compared to non-Aboriginal people. When we age standardise this, the rate ratio is only 3, but that is probably because there's a healthy survivor bias. So if you're Aboriginal and you live until you're 65, you must have pretty good overall health. And so that can actually obscure the disparities that we're seeing at those younger age groups. So age standardised incidence is approximately 3-fold greater overall, but when stratified by age, when you're looking at those aged less than 55 years, you're seeing significantly greater disparities. And so now looking to the larger study, the one with 675 Aboriginal patients, what we're looking at the top graph is the incidence rate per 100,000 population, Aboriginal patients in blue and non-Aboriginal patients in orange. And this is looking at total strokes and fatal strokes on the right-hand side. What we can see from the rate ratio graphs on the bottom is that the rate ratios are consistently elevated, but more elevated in younger age groups. So in those 20 to 54 years of age, the discrepancies are much more pronounced. And unfortunately, even more so when looking at younger age groups with fatal stroke events. I haven't gone into detail here, but as you can also imagine, there was also a greater recurrence rate of stroke. So Aboriginal patients who are younger are not only experiencing excessive rates of first ever stroke, but they're more likely to have a second stroke. And that's particularly important because we need to be ensuring optimal secondary prevention to prevent these recurrent events. Now, what's really interesting when looking at the Aboriginal population who've experienced stroke is actually to look at the proportions of different types of stroke. The textbooks say Caucasian populations, 85% of strokes are going to be from ischemic stroke and 15% of strokes are going to be from intracerebral hemorrhage. Now, 15% is still a significant number, but it's a lot lower than what we're seeing in the Aboriginal population. This is relevant because intracerebral hemorrhage is associated with a much more significant morbidity and mortality. At 1 year in the overall population, 55% of patients who've had an intracerebral hemorrhage will not have survived. And the mortality and morbidity is considerable. So looking now again at the Central Australia population, 26% of incident events in this population were attributable to intracerebral hemorrhage. And this compares to only 9% in non-Aboriginal patients. There was a comparable proportion of subarachnoid hemorrhage between Aboriginal and non-Aboriginal patients. Now to the larger data linkage study, what we could see is, again, what we'd observed in the Central Australia study was consistent with what we're seeing in larger jurisdictions. But in particular, when we're looking at the younger age group, 21% of strokes in this age group were attributable to intracerebral hemorrhage in the Aboriginal population. And this compared to just 13% in the non-Indigenous population. It's also worth mentioning that a significant proportion of patients with stroke had been coded with their ICD codes as being unspecified. And this reflects potential disparities in terms of the investigations that were undertaken or the documentation or the follow-up. Having almost 16% of young patients having undetermined etiology of their stroke is really far, far higher than we would want to see it. When I'm seeing patients in clinic, no matter where I'm seeing them, I want to know the cause of the stroke so I can ensure that they're on appropriate secondary prevention. But you can bet if I'm getting anyone under the age of 55, I am going hunting as hard as I possibly can so that we can get to the bottom of that. And as I've mentioned, there's a greater proportion and there are also greater rates of intracerebral hemorrhage at younger ages, particularly in women. Aboriginal women between 20 and 54 years of age were having particularly high rates of intracerebral hemorrhage when compared to their non-Aboriginal counterparts. This disparity was not as apparent in the older age groups. And so then we know the types of stroke: ischemic stroke, intracerebral hemorrhage or subarachnoid hemorrhage. But then what are the cause of those underlying strokes? That's often a question that I get asked, and I ask myself when I'm seeing patients in clinic. There's been very few data previously published on stroke etiology. What we found in the Central Australia study, which, because it was involved case note review of all the patients, allowed us to actually determine the presumed etiology of the stroke, whereas linked data doesn't allow that degree of granularity. As you might expect, there was a greater proportion of patients experiencing cardioembolism, the Aboriginal group compared to the non-Aboriginal. Much of this is driven by rheumatic heart disease. A lot is also just valvular disease, infective endocarditis, and that was only compared with only 10% in the non-Aboriginal group. Additionally, a substantial proportion of these patients had an etiology that remained undetermined. With intracerebral hemorrhage, and I should mention we're talking here about spontaneous intracerebral hemorrhage, we're not referring to traumatic bleeds, etc. Most in the Aboriginal cohort were of hypertensive etiology, secondary to hypertensive arteriolosclerosis. There was very little cerebral amyloid angiopathy, just 5%. And this isn't surprising given a very low median age, given amyloid angiopathy is typically something that we see in older adults. Still, a significant proportion of these patients, the etiology of the hemorrhage remained undetermined, and this was often because patients had not had full vascular imaging performed. Now looking to case fatality. So what I mean by this is the proportion of incident events and looking at those patients with incident events who died compared to the total number, so presented as a proportion. So the age standardised case fatality in the Aboriginal group in the larger study, the data linkage study, was nearly twofold that of the non-Aboriginal cohort. And considering the rate of intracerebral hemorrhage is substantially greater, this was perhaps not a surprising finding, but was really concerning that over 28% of our Aboriginal patients with first ever stroke were actually dying of their stroke. There was also a greater comorbidity burden, and this is important because we're dealing with a younger cohort who had more comorbidities at younger ages. So looking at the younger cohort, 20 to 54 years, there was a significantly greater prevalence of almost all traditional cardiovascular risk factors. In particular, as I mentioned, rheumatic heart disease. So 5% of these patients were having rheumatic heart disease, and those are just the ones that had the ICD codes attributed to them. Chronic kidney disease, 17% in this young age group versus 1%. And diabetes, 40% versus 11%. Looking at the cohort that I work with in Alice Springs, I was working with some of my endocrine colleagues who told me that they did an audit that's as yet unpublished, looking at the prevalence of diabetes in admitted patients. And in those aged 40 to 50 who were admitted to hospital at Alice Springs, Aboriginal people, over 90% had diabetes compared to less than 10% in the non-Aboriginal population. So, to summarise what we now know about stroke in Aboriginal Australians, we know that Aboriginal Australians experience earlier onset of incident stroke, greater age standardised rates of stroke, a greater prevalence of cardiovascular comorbidities occurring at younger ages, and a greater proportion of intracerebral hemorrhage, again, occurring at younger ages. Again, I'd just like to bring us back to what we were talking about at the beginning, and this is really significantly influenced by the social determinants of health and the ongoing impact of colonisation. And stroke research with Aboriginal Australians, what we can see from this study is that the methodology of gold standard studies may not be appropriate for studying the Aboriginal population or other minority populations because you're not getting the case numbers, so you're limited with case ascertainment. Traditional methods of age standardisation don't adequately illustrate the burden of disease. So when I was showing the World Health Organization standardised numbers, just threefold overall, that really wasn't highlighting those disparities in those younger age groups. And I haven't gone into it today in detail, but in Angela's study with the prospective stroke incident study, what we found was that there were a lot of challenges obtaining informed consent. The concept of consent is quite different in the Aboriginal population. They consider consent to be something that needs to be made on a community level. So they want to discuss it with their family, they want to discuss it within their community. It's a much less individualistic society than perhaps what we live here in Melbourne. So I've talked about the doom and gloom, but as I mentioned, I don't want to focus on this discourse. I think it's really important to focus on what can be done about this, how we can work towards greater equity and equality in care and outcomes. I know it's a bit corny, but I've put a photo of the road up there. This is a picture I took when I was up in Alice Springs, would have been 2 years ago, and driving out to the West McDonald's Ranges, which you can walk the Larapinta Trail. And if you're ever in that neck of the woods, I couldn't recommend it more highly. It's absolutely beautiful hiking through an area of the country that's quite unlike anything else. So, talking through the steps of improving stroke care, cardiovascular care, and also this really can be extrapolated to many other chronic health conditions in Aboriginal population. So firstly, primary prevention is the critical first step. And this is, of course, underpinned by the need for a fundamental access to human rights, which is designed as equitable access to safe and potable water, sanitation, food, housing, education, and gender equality. Additionally, as I've already outlined, cardiovascular disease occurs at significantly younger ages in the Aboriginal population. A recent consensus statement published in the MJA recommended that cardiovascular screening should occur from age 18 at the latest. And this is quite different to what we're doing in the Caucasian population. We should particularly be targeting risk factors for intracerebral hemorrhage, so hypertension, diabetes, chronic kidney disease. Additionally, it's all very well to say we need to do primary prevention, but we need culturally competent healthcare providers who understand how to communicate and deliver culturally safe care. The next step is primary prevention's failed and a stroke's occurring. Early recognition of and response to stroke symptoms and signs is critical to ensure that we're able to deliver appropriate hyperacute care. And this will involve working with different communities and language groups to provide culturally safe education. I was catching up with the Aboriginal liaison officers in Alice Springs a couple of months back, and they were explaining to me that no one in their community knows what a stroke is. They think a stroke is that they've been cursed and it's a shame job, and they don't want to tell anyone that they've had these symptoms because it means that they might have done something bad, or someone thinks that they've done something bad, and they're very ashamed and actually actively don't seek healthcare as a result. We then need to improve access to time-critical care. I got a little bit of trouble with the Department of Health in the Northern Territory when I told an ABC News reporter that it could take 18 hours for someone in a remote community to get down to Adelaide for acute treatment. I said it because it was the truth, and it was probably an underestimation, but that's the reality. We're dealing with people in remote communities who have, even if they pick up the signs of stroke, even if they contact, that you can't call 000 in a remote community. You have to go to your local the local healthcare area. There may not even be a nurse there. There might be a local health worker who then has to call Alice Springs Hospital, arrange a retrieval. If you happen to have that on the weekend of the FINC races, there'll already be all the planes deployed to the races, and so chances are you won't be able to be retrieved for over a day. One of the solutions that's being proposed is work that I'm doing with the Australian Stroke Alliance. The Australian Stroke Alliance is an organisation partnering with 40 partners across Australia to work to develop lightweight, portable and affordable brain scanners for deployment in standard road ambulances and world-first air ambulances. So many of you may have heard of the mobile stroke unit, the stroke ambulance, which is something I work on in my free time. This is quite different because the stroke ambulance has a scanner that's half a tonne and needs a bariatric truck to drive it around. What we're looking to do here is actually develop new lightweight devices. The one that's being shown in this is the MicroX CT scanner, which is a miniaturised cone beam CT, which is nearly ready for our early trials. It's almost finished being built. And this is estimated to be 75 kilos as opposed to half a tonne, which is the next lightest. And so this gives huge potential for improving access to pre-hospital care. Because if you then have someone in a remote community having a stroke, you just put the scanner on the truck, or sorry, not on the truck, on the plane, fly the plane out, scan the patient where they are. You can immediately diagnose if they've got an ischemic stroke versus intracerebral hemorrhage. Making that diagnosis is critical for delivering care. The Interact 4 trial came out, I think, 3 weeks ago now, which showed that pre-hospital lowering of blood pressure is incredibly beneficial for patients who've got intracerebral hemorrhage, but extremely harmful if you've got an ischemic stroke. And so we need to make that diagnosis, and that diagnosis hinges on the imaging. And so the progress that's being made with the Australian Stroke Alliance is really exciting. We also need improved in-hospital care. This includes hyperacute management. One of the barriers to delivering hyperacute management in the regional setting is you don't have dedicated stroke specialists, you may not even have access to imaging. And so improving hyperacute management is going to be done through increasing telehealth and increasing access to imaging devices. We also need improved in-hospital secondary prevention, so making sure that we're doing all the tests that are needed to identify the etiology so that the patient is on appropriate secondary prevention, as well as improved access to rehabilitation services. I remember one of the patients who was interviewed in the qualitative study as part of the SAINT study, a 40-year-old man who'd had a big stroke in Alice Springs, but his community was 5 hours out of town and absolutely no rehab services were available either through the hospital or his local community. So what he did is he went and found a bike and got his nephew to take the bike wheels off and set himself up with his own little bike rehab device and sort of did his own rehab, which I thought was very impressive for someone who never had any reliable access to healthcare. And while I commend him for his efforts and he actually did really well, we can't be offering that sort of healthcare to people in a country that is as privileged as we are in Australia. So what have we done as a result of the SAINT study in particular? So this has helped us to identify disparities in stroke care and determine where stroke services need to be focused and where underservicing has been found. And this has led to improved stroke service provision, including through telemedicine. In particular, Alice Springs Hospital, before I was working there as a junior doctor, didn't have a stroke protocol, but we worked together to write and implement its first protocol, along with consultation from the Royal Adelaide. We then developed a thrombolysis protocol, which was, again, stroke thrombolysis was not available in Alice Springs before 2019. And now it's routinely available. This is then supported through telemedicine. We've also been working to ensure we have appropriate stakeholder feedback. So when we do this research, we then need to get the information back to the communities. So I've been working with the Aboriginal liaison officers in Alice Springs and hoping to do broader work so that these findings can be communicated effectively. We've also obtained funding for further stroke research in Central Australia, and we're also expanding the reach beyond just stroke to epilepsy and hopefully other services in the future. So, to summarise, Aboriginal Australian voices should be the ones to drive strategies employed to tackle the greater incident rates of stroke for the reasons I've been describing. There's clearly a need for region-specific, culturally safe interventions for primary and secondary prevention. And I'd like to take a moment to acknowledge all of my collaborators, in particular my Aboriginal researcher collaborators, Alex Brown, Angela Dos Santos, Luke Birchall, and many others. For everyone's interest, if you do want to have a bit more of a read about this, I've included some really valuable resources about doing research with Aboriginal Australians. Tanya Hurier is a Maori researcher who developed the Consider Statement, which is looking at ways to improve the conduct and reporting of health research involving Indigenous peoples worldwide, and it's a really fantastic resource. And then there's work by Drs. Paredes and Bainbridge as well that discusses the history of Indigenous health research. So I'm very happy to take any questions. Just another plug for visiting Alice Springs. This photo was from the Ilpapa clay pans when I was there 2 visits ago. Absolutely stunning. That's it from me. Thank you very much.
Thank you very much, Hannah. That was a wonderful presentation. So before it's open for questions, if you have any that you would like to ask, I can start with one thing. It's fantastic to see that the studies lead to actually protocols and implementation of all this practice. So I'm wondering if on the prevention side of things, what we can or may be able to do.
Yeah, fantastic question. And I like to break this down into both primary and secondary prevention. Primary prevention, I guess the bottom line is that we need better access to the fundamental basis of human rights. And so what we can do beyond our role as healthcare providers and researchers, I think is, lobby our local governments to ensure that, if you live in Papunya 5 hours out of Alice Springs and you don't have access to power, that's considered unacceptable. I think even just people having knowledge and turning away from that idea that, it's just because Aboriginal people and communities smoke and drink all the time. It's like, no, they actually don't have access to safe water. So I think really recognising what underpins this is really important. In terms of primary prevention, screening from 18 years of age or earlier for cardiovascular risk, and being really proactive about that, supporting Aboriginal health workers and researchers so that they have capacity to do those things is really critical, and identifying any barriers to Aboriginal people accessing care. A lot of the time what you'll find is, I have a pretty high rate of patients not attending their appointments in my clinics, and I'll call the local health centre, say, have you seen this person? And say, oh yeah, they're looking after their auntie. We can send the truck out and find them, see if they're free. I'll often then, just allow them to come to my appointment 4 hours later, because I just accept the fact that, it's beyond their control. They weren't able to come in. And so allowing flexibility when you're looking after, when you're working together with Aboriginal people to try and improve their health, is critical for primary prevention. The secondary prevention, particularly with stroke, one thing I didn't mention is that the Stroke Foundation are developing more resources looking at improved education around stroke for patients and their families. There's one particular Aboriginal specific research resource called the Our Stroke Journey, but this was developed specifically in response to communities' needs in North Queensland. So recognising the difference between different communities, it's very much not a one-size-fits-all. And so finding ways to communicate this effectively with different communities is crucial. And then also supporting people, healthcare providers in regional settings so that they're actually empowered to provide the secondary prevention that patients need is really critical. There aren't any neurologists or stroke specialists that work out of Alice Springs. We're very fortunate that Dr. Anna Holwell, who's the head of medicine at Alice Springs Hospital, is an incredible advocate for patients with stroke and has a huge amount of knowledge despite having not done dedicated training. But providing her and other clinicians in her position with support, whether that be through telehealth, whether that be through doing education, actually going up there, teaching the local doctors, working with the allied health staff, I think is really important. So those are a few ideas.
Thank you very much. Any more questions?
We have some online, Zoe, as well.
Yeah, sure. Okay, so there are a couple of questions actually online. Oh yeah, you will be able
Yes,
to
so
see it.
one is the reasons for health discrepancy in myriad, many are out of control of the medical community. What are the easiest low-hanging fruit? I'd say from my perspective, tackling hypertension, diabetes, chronic kidney disease would underpin everything. So if you're seeing patients, firstly asking them if they're Aboriginal. A lot of Aboriginal people don't look Aboriginal, but may still have the risk factors that are conferred. Being very proactive in terms of asking about those risk factors, even if they're not volunteered. Exploring the treatment options. I think we need more research looking at effective treatments in Aboriginal people with cardiovascular risk factors. Really exploring barriers to them taking medication, for example. I'd say that would be the low-hanging fruit. I'm also interested if anyone else has any opinions in the audience. I'm open to all opinions there.
And so there's another one asking if Anna could speak to how you incorporate the perspective of Aboriginal people in the design and conduct of your research.
Thank you. That's a great question and underpins all the research that I've been involved with in Aboriginal Australians. Step one is it's not about me thinking up a research question and doing the research and involving the communities and stakeholders after the fact. It's about spending time developing relationships with the Aboriginal communities and stakeholders and listening to them, asking, what do you care about? What do you think is a problem? With the SAINT study, the Aboriginal communities are saying, this is a problem we care about, we don't understand it, we don't know what's going on in our community, so can you do something about that? And then it's about incorporating and empowering Aboriginal researchers to be central to the conduct and design. So the SAINT study was led by Professor Alex Brown, Aboriginal researcher. We collaborated with numerous Aboriginal researchers in the project, Angela Dos Santos, Odette Pearson, Luke Birchall, many others who are absolute superstars in this space. And also having ongoing community feedback. So while we were doing the research, we would have meetings with Aboriginal elders and stakeholders, say, well, this is what we've found so far, are we doing this the right way? Do any other questions come up for you? And then once we've got more of those answers, ensuring that again, we go back, we do the feedback with the stakeholders. I'm meeting with the Aboriginal liaison officers saying, this is what we've found. Does that make sense to you? What do you think we can do? What else do you want to know? And sort of at every stage of the research, prioritising Aboriginal researchers, stakeholders, communities, ensuring that their voices are leading what we're doing at all times.
Thank you.
Terry?
I think there are also some questions up there as well.
I think it was.
No, I think these are like trying to coordinate.
I've got a question.
You go.
So thank you, Anna, for a most illuminating talk, and also thank you for reminding us how beautiful the territory is. I can second your approval of the Larapinta Trail. I did that a few years ago, and it was just incredible. Off the back of that second question about kind of research and how we frame our research, I'm quite interested in the way that language can influence and create sometimes quite subtle biases and have unintended effects. And I think from that point of view, I was very interested in your was the discourse of deficit. I think you mentioned that phrase. And it sort of occurred to me that we're really encouraged to sort of frame things as a deficit, particularly when arguing for greater healthcare delivery or arguing for grant funding and so on. We don't identify the problem, identify the unmet need or the lack. And so it's almost inherent in the language we use for all this sort of stuff that there is this discourse of deficit. So I'm just curious about how you've kind of overcome that, and if you had any tips or advice for people who are looking to get more involved in this sort of a research and how they could kind of, you know, change their language or how they could better work towards avoiding this discourse of deficit.
Thanks, Hugh. I think that's a really fantastic question, and one that I'm unfortunately still grappling with. I asked a similar one, I think at last year's NAIDOC week of an Aboriginal professor. I said, you know, how do we actually get past this? It's just such a huge paradigm shift for Westerners to not say, well, this is the problem and this is why we care about it, and how are we meant to talk about the problem and fix the problem if we don't acknowledge the problem. I don't have a great answer, but I'll tell you what I've been told by Aboriginal people, experts in the field. I think firstly, from a practical point of view, and something I didn't do in this research, but I will do in future research, is actually take away the comparator. So you can look at the rates, but you don't necessarily need the non-Indigenous comparator, because that's where the deficit becomes apparent. I think that it's helpful as a baseline to know that there are these disparities, but we don't need to do any more research to prove it, because we already know it's there. At least I'm talking in the stroke space. But rather, we've got a baseline, we need to now act upon it and improve it, and we can measure it against itself, but not against other populations. It's quite interesting. Some of the work I did in my PhD that I didn't present here was looking at stroke in Indigenous populations in developed countries worldwide. And something that we were told by a lot of different populations, in particular Native American and Alaska Natives, is that they do not want to be compared to any other group. And so when research is being designed, firstly think, do we need a comparator that is a non-Indigenous population? Secondly, rather than talking about the deficits in terms, again, of behaviour or purely risk factors, reframing to say, well, this is a problem, but that's because of, you know, colonisation leading to these ongoing problems. Because it's fair to say that there's a problem, because there is, but acknowledging what really underpins the problem is what's been recommended by the Aboriginal people I've talked to about this. And then again, having a solutions-based approach, saying we've measured a problem, but this is what we're going to do, and highlighting the strength and resilience of the people involved, and also using the process to promote and support Indigenous researchers and so forth. All of those things are actually working to address the inequities. So that's what I've been told, and I think it resonates with me, but I do acknowledge it's a really challenging thing to do and something I continue to struggle with.
Thank you.
Oh, look, good question. Close the gap hasn't been terribly helpful in the way that it's been done, and it is a bit of a focus on deficits. Again, I'm not sure, because I think that the deficits discourse is felt by different people in different ways. I think some people would think close the gap is working towards a solutions-based approach and find it empowering. Some people would just say, well, this is just, you know, other, you know, white man inventions. So I think it'll depend a little bit on the individual you're talking to, but yeah, excellent point.
Thanks, Anna, and congratulations, and thanks on part of the school for presenting such an important and relevant talk in Reconciliation Week. Just wanted to ask a question based a little bit on one of your answers, a couple of removed. Is there any evidence that some of the rates of stroke and cardiovascular disease might have inherent genetic factors as well as the obvious socioeconomic, cultural, and from that, when we're looking at trials of treatment and extrapolating them to Aboriginal populations, is that necessarily relevant? And should we be looking at doing treatment trials in the Aboriginal populations per se? Because it may be that interaction, genomic and other factors might mean that what is true in a broader non-Indigenous population may not be true in the Indigenous population.
Thanks, Terry. I think that's a fantastic point. To the first question, sort of what is known about the genetics, next to nothing, but there is work that's being done by Professor Alex Brown through ANU and the Telethon Kids to do some of the first ever genetic studies looking at cardiovascular and stroke risk in the Aboriginal population. So I'm really excited to see the work that they're doing, because my sense is that the degree of disparity we're seeing does not account for the outcomes that we're seeing. There's a lot of disparity, but it's not enough to really account for it. And sure, I think we're not measuring some of the things like chronic stress and so forth that of course predisposes to stroke, cardiovascular disease and other chronic disease. But there's more to the story and we don't yet know. It's obviously been very hard to do the research because of the historical problems. There was a study that was done, basically stealing Aboriginal people's blood to try and prove that they were prone to addiction. And this is recent history, unfortunately. About the efficacy of medications in the Aboriginal population, I think that's another really important question, and we don't know a lot about it. If you look to other populations around the world, Black Americans, we know that antihypertensives that are used in the Caucasian population don't necessarily work as effectively in Black American population. So absolutely, I'm sure that there are differences, but I have no idea what they are. I think
The answer is probably we should be doing trials, shouldn't we?
Absolutely.
And just on the genetics point, we do know in the population that genetics are a really important component of your risk factor for cardiovascular disease that's non-modifiable. Another, I better hide the microphone, no one should give me the microphone, but it's got my mind racing. Another sort of related question is looking at the other end of the lifespan, and there's an increasing focus and concern across the community in dementia disorders, Alzheimer's disease and others. And we increasingly understand with Randy Brotman and from here and others about the importance of cardiovascular health underpinning the risk factors for Alzheimer's disease and other dementias. Do we have any data on the incidence of Alzheimer's disease or dementia disorders in the Indigenous population? Is there reason to believe that that also might be, without doing comparisons, also might be an important issue?
Yeah, another great question. Thanks, Terry. It's actually the particular topic of my PhD student, Antonia Clark, looking into that in particular. There's been very limited data looking at it previously. Antonia has recently was finishing up a systematic review looking at that in Aboriginal people and other First Nations populations, and it's really interesting to see that there are discrepancies in the incident rates. One of the things that we're looking at through her work is also not just the rates within just the Aboriginal population, but looking at the impact of rurality on the incidence of Alzheimer's, because of course it's going to be picked up less frequently in people living in remote areas, but the rates may well be greater in those populations. So work is being done. There's not a lot out there at the moment, but watch this space and we'll hopefully know more soon.
Great. Forward to the next talk.
Thank you, everyone. Oh, Danica. We'll probably have the last question, and more questions will have to wait for the last one.
Thanks, Anna, for a fabulous talk. I had a fairly specific question about the patients with rheumatic heart disease and whether or not you have any granularity around the duration, sort of since diagnosis with RHD, or kind of the age at which they were first diagnosed with rheumatic fever, if that's known.
It may well be known. It's not my particular area of expertise, so I'm not able to give you a specific answer, but what I do know from working there clinically is it's often picked up young, but often patients who are a lot older than you'd think are presenting with it. So not just kids, but people in their 20s presenting with acute rheumatic fever and going on to have RHD. So it's really interesting because it doesn't necessarily behave like it's supposed to in the textbooks. I think the other thing to mention in the Aboriginal population is that autoimmune conditions aren't behaving in quite the same way as what we're expecting in the Caucasian population. I have a lot of patients with lupus in Alice Springs, but a lot of patients with brittle myasthenia gravis. So I do think that there's a lot of a sort of an autoimmune story that we don't fully, have our grips on at the moment. So not sure. There is work out there by Judy Katzenellenbogen and also Ross Roberts-Thompson, though, that I think would be able to answer your question.
Thank you, Anna. Please join me in thanking Anna for wonderful presentation.